leave this room, it kind of protects it. Well,
Not
no.
anymore.
All right, can y'all hear me okay? Can you hear me pretty well? Okay, so I'm Elizabeth Turner, rheumatology, and I was going to talk to you guys about ANCA-associated vasculitides today. Last time I was here a few months ago, we did large vessel. So now we're kind of going to the other end of that spectrum. Let's see if they'll let me, what do I do, enter? Nope, that's not it. That jumped way ahead, so. Oh, maybe I just used the mouse here. I don't know why I did that though. Yeah. Yeah, okay. I don't know why it jumped like that. Okay. So you can kind of see the schematic here. That just gives you an idea, thinking about the vascular tree again, and where we're going to be talking about. Last time, I was talking to you on the large vessel. We talked about Takayasu's and giant cell. Now we're moving more toward this small end. There's a little bit of overlap with medium, but we're going to be talking about the ANCA vasculitides. This is another schematic just to think about the different size of vessels. And again, we're going to be over here, and it touches a little bit into medium, but mostly small with this. How can I get rid of that right there?
You have to move it to the bottom. It's hard for it to go away altogether.
It is, okay, because, aha, okay, that'll be better. So when I was preparing for this, I was listening to one of our rheumatology lectures on ANCA vasculitis, and this was by Dr. Monik. And he's a rheumatologist with Brigham and Women. And this is what he shares with his medical students, residents, to have them kind of think about vasculitides. I was like, that's amazing, because it kind of gives you a way to think, is this bad or not? And could it be vasculitis or not? And if it is, where does it fall out? To me, it's almost like something you may want to keep on your phone to pull up if you start seeing patients that are of concern, or when you're studying for boards. It just gives you a way to think about things. So the red flags for considering vasculitis: if you have a patient with new headache, FUO, acute vision loss, you're going to be thinking about GCA. If you have absent or diminished pulses or blood pressure, that would be Takayasu's. That's what the TAC there is for, is Takayasu's or GCA. So those are large vessel vasculitides. They are now using the terminology multifocal neuropathy. We always, back in the day, called that mononeuritis multiplex. So if you have people that are coming in like with foot drop or wrist drop, just sudden onset, mesenteric ischemia or digital ischemia, you're thinking about polyarteritis nodosa. You're thinking about the ANCA-associated vasculitides and cryoglobulinemia. Palpable purpura hits quite a few things: HSP, ANCA-associated vasculitides, cryos, infections can do it, drug-induced. The small vessel vasculitides can do that. Pulmonary hemorrhage, glomerulonephritis, you're going to be thinking about ANCA-associated vasculitides. A multi-system illness with eosinophilia, that eosinophilia, you're going to be thinking about EGPA. Destructive nasal inflammation, you think about Wegener's GPA. And inflammatory eye disease, which can hit a lot of things, but Behçet's and ANCA-associated vasculitides, and then other rheumatic diseases, because there are quite a few of our rheumatic diseases that'll give you inflammatory eye disease. But I just thought that was kind of in a thumbnail sketch, a good thing to have, just to look over to make you think, could this be a vasculitide, and then where might it fall, and kind of get you on the right path and working it up. So our ANCA-associated vasculitides, you're probably pretty familiar with to some degree. I'm sure by now you've seen some Wegener's GPA. There's also microscopic polyangiitis, the eosinophilic granulomatosis with polyangiitis, EGPA. We always called it Scherg-Strauss, but now EGPA. There is a renal limited vasculitis, and basically what unites these diseases, in addition to the vasculitide component, is the ANCA association. The major autoantigens with the ANCAs are primarily PR3 and MPO, but LAMP2 is also part of that, not one we routinely check for. What tests are used to detect the ANCAs? We use immunofluorescence for C-ANCA, P-ANCA. And I know if you've been doing internal medicine words for a bit, you're already ordering these. We routinely now get PR3 and MPO. That's pretty much that when you order at Erlanger, when you order the ANCA profile, I think you routinely get MPO PR3. When I do, I get that. So I'm assuming that's not just something we've set up for rheumatology, but you do want to always check that. ANCA, P and C ANCA alone aren't sufficient. You want the ELISA as well. So the C ANCA is staining of the neutrophil cytoplasma, P ANCA, the nuclear cytoplasmic staining. This is an immunofluorescence of the C ANCA. I'm sorry, that is, maybe if I move it back up there now, of the C ANCA. And then that's an example of the P ANCA, the perinuclear staining with immunofluorescence. This goes through some classification. I'm not going to go through all of that, but suffice it to say that in the 1990s, they started trying to zero in on what was going on with these vasculitides. They didn't have ANCA availability at that time, so it made it a little bit more cumbersome and less specific. Chapel Hill Consensus Conference 2004 and 2012, they worked on definitions of disease, but didn't really zero in on classification criteria. Then UR over in Europe, they worked on some things, kind of meshed the ACR and the Chapel Hill Consensus Conference, but ultimately we now have a more specific classification system with the DC VAS, and it gives us better criteria for defining GPA and MPA. It should be recognized that there is some overlap in these diseases. Sometimes it's a little tricky to say, especially at onset, it's this one or that one. The other thing I would point out is these diseases evolve a bit. So a patient may present with one manifestation. They may present with inflammatory eye disease to the ophthalmologist, and nobody may see them for a month or 6 months or a year, and then down the road, they develop something else. So it's, and the ophthalmologists are good at screening these patients, looking for ANCAs and PR3 MPOs, but it's just something to recognize. My first case in fellowship of a Wegener's GPA patient was a patient that in the summer had gone to ophthalmology with inflammatory eye disease and been treated effectively, and then about 5 to 6 months later wound up in the wards and had renal involvement. And young guy, he did well, but that just right out of the gate was my experience with watching how the disease could evolve over time. The prevalence of the ANCA-associated vasculitides, GPA is our most common ANCA-associated vasculitis. When they looked at a study, Norfolk, England, the incidence 8.5 cases per million. The microscopic polyangiitis was about half that at 3.6, and then EGPA, the Scherg-Strauss, at 2.4 cases per million. So not a common disease. What is common is rheumatoid, lupus, PMR, and GCA. And like I said, last time we talked about GCA, I'm sure you all have gotten some experience with GCA by now. Thinking that through, when I'm looking at your mix-up questions that are just coming out, it seems like they are much heavier on lupus than they are on the ANCA vasculitides. That doesn't mean these aren't important, but if you're going for the money, you probably want to spend more time looking at these that are much more common that also wind up in the hospital, so particularly SLE. The mean age at diagnosis, 41. There's a big range in the age as far as who can present. Kids can get it to 16% roughly, less than 18. Male-female ratio equal. Lots of whites get this disease, but it can be seen in every ethnicity. GPA, the vasculitis, we see upper and lower respiratory tract involvement with granulomatous vasculitis, mostly small vessel. There can be inflammation, there's necrosis. The characteristic of the glomerulonephritis, which will be in here again, is that it's pauciimmune, focal and segmental, necrotizing, and can be crescentic. Strong association for GPA Wegener's with ANCA and P3 antibodies, but just because it isn't that pattern doesn't mean you can rule out GPA, but usually that'll be the antibody pattern you're seeing. Generalized GPA involves all three anatomic sites. So upper respiratory tract, lower, and kidney. Limited does not involve the kidney. And in general, if they present with limited to upper respiratory in particular, it typically stays that way, although occasionally it can become generalized in kidney involvement. So for a patient that's identified as having limited upper respiratory tract involvement, you still want to be checking kidney function periodically, probably about twice a year, to make sure nothing's changing there. So we commonly see the limited in women, and in women they can get this chronic recurring disease of the sinuses that can cause a saddle nose deformity. We try to figure out if that's going on before the disease progresses to that. It is considered a primary vasculitis syndrome, but primarily what we're seeing is the granulomas occurring outside of vessel walls. So as far as, let me move that again. The paranasal sinuses, 50% present with a chronic sinusitis. Ultimately, about 80% will have that. They often have staph, and that can predispose to relapses. The nasal mucosa, there's a chronic inflammation. We think about the nosebleeds, the chronic crusting, the dark secretions that can come out of the nose. They can develop the nasal septum, perforations. They can get disruption of the cartilage, which can lead to that saddle nose deformity. They can have oral ulcers. They can have the ear involvement. And then they also can have the laryngeal and tracheal mucosa involvement and have hoarseness and ultimately subglottic stenosis and respiratory insufficiency, which is obviously a big deal. This is a picture of the saddle nose deformity. We don't see that a lot, but occasionally. The lower respiratory tract, 50% of GPA will present with that. Ultimately, 85 to 90% will have pulmonary disease. A third of the patients with chest X-ray changes won't have symptoms. A lot of patients that don't have chest X-ray findings but have pulmonary symptoms will have abnormality on CT chest. So just because you have a normal chest X-ray doesn't mean nothing's going on in the lung parenchyma, and a CT chest will be more effective at identifying that. Acute inflammation results in infiltration of the neutrophils, inflammatory cells in the vessel walls, alveolar spaces. Capillaritis can occur. I know that you guys are seeing that on the inpatient side in the units with alveolar hemorrhage. Chronic inflammation, you can get quite a destructive process. It can even lead to fibrosis. You can commonly see nodules associated with it. This is pathology looking at a granuloma with necrosis. The smaller area there is looking at a giant cell. So that this would be typical lung pathology for GPA. Here is a chest X-ray, which you can get feeling for the lung nodule with cavitation and drainage. And then this next is a CT. These aren't the best pictures, but CT chest that is of the same patient, which on chest X-ray, you don't really appreciate all that's going on, but CT chest obviously identifies a whole lot more with multiple nodules. And then the kidney, clinically evident kidney involvement occurs about 15 to 30% at presentation, but ultimately 50 to 80% will have. As we mentioned, it's posse-immune. We don't see lots of deposition of immunoglobulin, immune complexes or complement, but we do see some. So it doesn't mean zero, it just means not a lot, as opposed to the lupus renal lesion, which would have lots of immune complex complement deposition. It can have crescentic changes there as well. Renal vasculitis can occur, but it's not likely to occur. A lot of times and commonly, there are no symptoms, especially early on with the GN, and we just detect it based on what's going on in the urinary sediment. So the active urinary sediment with blood, pyuria, proteinuria, cellular cast, and then obviously we're monitoring the creatinine. And that can, untreated, lead to acute or chronic renal failure. Multiple other areas can be involved in GPA. The eye, they can have the retroorbital pseudotumor, all the different inflammatory processes of the eyes. Many of them can be present in GPA, from scleritis, episcleritis, uveitis, conjunctivitis, optic neuritis, nasolacrimal duct occlusion, which can be related to the sinus congestion, renal artery thrombosis. And that can be the initial manifestation of disease. They can have skin involvement, ulcers, nodules, vesicles, and what we think of commonly as a palpable purpura. They can have joint complaints. Maybe they're just achy, but they can also have a migratory inflammatory arthritis and occasionally synovitis. The neurologic involvement, we talked about the mononeuritis multiplex, which cerebral nerve biopsy can help define that. They can have chronic pachymeningitis, cranial neuropathies, ocular palsies, strokes, seizures, brain hemorrhage, just a lot of different neurologic issues there. This is a lady who has the retroorbital pseudotumor, and the eye that's actually off here is the left eye, which is not moving. And this is the MR looking at that, and you can see infiltrative process there. And if you Google pictures of sinusitis and retroorbital, you'll see good slides of that as well. Here is the palpable purpura. Probably you've seen some of that already in your training, and the differential is pretty broad, but in the right setting, that can be a huge clue for GPA or any of the ANCA associated vasculitides. GPA can have cardiac involvement, not a lot. I've never seen that. GI, intestinal perforations, again, not common. GU, again, not common, but possible. They can have salivary gland mass, pancreatic mass, and granulomatous infiltration of the liver. So our labs, we're going to check ANCAs, PR3, MPO. 80 to 90% are positive ANCA. About 10% are negative, but the 10% are negative, that you can be negative with GPA, but that's unlikely. It's more common for the limited disease to be negative rather than the systemic. They will typically have an anemia, have high white count, high platelets, elevated sed rate, CRP, low albumin, kind of all the things that make you think of a chronic inflammatory state. The urine, you will see an active urinary sediment with white cells, red cells, protein, cellular cast. And then the creatinine, it may be normal, but still have a lot going on in the kidney. So a normal creatinine doesn't rule it out. We also, to think more broadly in our differential, want to think about lupus, cryoglobulinemia, good pastures. We check for infectious etiologies, and those things are good to know as well in planning for treatment for your viral studies with Hep B, C, HIV, checking for quantiferon gold, blood cultures, complement, urine for protein. You would get, like we showed before, a chest x-ray. If there's pulmonary issues, most likely you'll be getting a CT chest. If there is eye involvement, sinus involvement, CT scan, head, sinuses, orbit, mastoids. If you're worried about subglottic stenosis, you'll go for the neck. Bronchoscopy, obviously, for that critically ill patient with alveolar hemorrhage. Biopsy is very important in nailing down the disease, and where you biopsy does make a difference because all biopsy sites are not equal. The renal location is going to be the best. Pulmonary, if you get open lung, get a large piece of tissue, that can be helpful. Transbronchial is just not as helpful. Sometimes that's all we can get, but it's not as helpful. Sinus biopsies are also not as helpful. So if you get a skin biopsy, a palpable purpura, you're going to have changes of a leukocytoclastic vasculitis. that really doesn't rule in or out anything. So the most beneficial site to biopsy, and typically the boards do want you to biopsy, and typically as a rheumatologist, we want you to biopsy. But the best bet is going to be on the kidney. So just other things you may think about: echocardiogram for pericarditis, again, very rare, but possible. Nerve conduction study for mononeuritis multiplex, and then also the sural nerve biopsy we talked about a minute ago. Thinking of the differential, the pulmonary renal syndromes, lupus, good pastures, and the workup for that to rule those things out. And then the cousin diseases of EGPA and microscopic polyangiitis, thinking about that too. Granulomatous infections can be a mimicker of GPA, TB, fungal, actinomycosis, syphilis, and particularly lung involvement. Bronchoscopy will be helpful for that. So upper respiratory involvement, intranasal drug abuse, cocaine, and there are the anti-neutrophil elastase antibodies that can help identify that. Pseudovasculitis syndromes, atrial myxoma, echocardiogram can help with that. Subacute bacterial endocarditis, cholesterol emboli, and especially in our older population, that's very possible and a common occurrence, actually. Angiography, skin biopsies can all help look through that. And then neoplastic issues can also be a mimicker.
Quick question. So we had a patient for, like, we suspected GPA.
Yeah.
They did not have renal involvement. And then we couldn't do renal biopsy for other reasons. Would we still do a renal biopsy if they only have lung involvement?
No, and I'm talking more about the generalized GPA, but so the patient you're talking about had upper respiratory and lower?
Yeah.
And were they ANCA, PR3? Or they were ANCA.
Weekly. And we started treatment on
Were they PR3 or?
she was getting plasma 3. She was like, we ended up giving her braces, and then new set of team came in and said, no, let's stop it, and then she would be compensated. She ended up getting a lung biopsy, but then I left the service.
Well, so ideally, if they've got renal involvement, you go for the kidney. If they don't have any renal involvement, if they don't have an active urinary sediment, I would not do a renal biopsy. But when I'm looking at the patient that kind of has, yeah, and if you get to choose where to biopsy, if they've got renal involvement, that ideally is what you would go for. Sometimes we have to treat without having tissue to, support the diagnosis. And certainly if they've got lung involvement, a biopsy would be helpful in other ways. A lung biopsy would be helpful in other ways also. So it sounds like you did the best thing for that particular patient. And if they're PR3 positive, that increases the likelihood if the scenario is kind of fitting. So, yeah. But yeah, if you can choose kidney biopsy. So for a super sick GPA patient, we are going to be treating them with high dose corticosteroids. Corticosteroids alone are not sufficient for controlling disease. Plex, that actually has gotten to be more controversial in the last year and a half. It's not officially recommended, but I will say it's kind of provider dependent. So if you think there is a possibility of good pastures going on as well, I mean, anti-GBM positive, Plex would be appropriate. And so we haven't totally ruled out the possibility of plasma exchange, but officially about a year ago or so, they based on a more recent study, are saying it doesn't seem to be beneficial. Treatment plans now, I know that you're probably seeing this as well. Traditionally, cyclophosphamide was the drug of choice. That has been replaced by rituximab. So the majority of the time, we're going to be using rituximab in these patients. Cyclophosphamide is still an excellent drug. It just has more risk and concerns with that. For cyclophosphamide, it can be given oral or IV. They both can be beneficial. Rituximab, the schedule for that, you can use the schedule like we use in rheumatoid arthritis, or they can also have that 375 milligram per meter square weekly for 4 weeks. Either one, there's not a preferred way. And it would seem a lot of times nephrology does the 375, rheumatology does the 1 gram for 2 weeks apart, but either way are effective. Limited GPA, so more just respiratory involvement, is oral prednisone plus weekly methotrexate. And we do a stronger dose of the methotrexate than where we would start for rheumatoid. Subglottic stenosis is a very difficult disease to treat. Thankfully, it is very uncommon, but they can try interlesional steroid injections, minomycin C, dilatation, but that unfortunately is a very challenging manifestation of this disease. We thankfully see a lot of these people go into remission, and then as far as deciding on therapies for remission, that also is provider dependent. I think a lot of us are seeing that continuing rituximab like every 6 months seems to be a very good way to go, well tolerated and controls disease well. But there are several different protocols you can try. You can do azathioprine or methotrexate, and those have shown to be good and maintaining remission as well. CellCept has fallen short, so while it works well in our lupus patients, lupus nephritis, it doesn't work as well as Imuran, azathioprine, or methotrexate for maintaining remission. And then, of course, prophylactic treatment, you worry about pneumocystis. A lot of these patients will be on Bactrim or Dapsone, and then ovarian sperm protection for those who get cyclophosphamide. The less common disease that is also related to GPA, microscopic polyangiitis. That one is a necrotizing vasculitis. It affects small vessels, capillaries. It also minimal immunodeposition. It's also the focal segmental necrotizing GN and pulmonary capillaritis. It doesn't have microaneurysms, so PAN would have microaneurysms. This does not. It does not have granulomatous formation, and that separates it from GPA. It also affects males and females equally, 30 to 50 years old, but can occur at any age. These patients present with a pulmonary renal syndrome with rapidly progressive glomerulonephritis. Often about half of them have pulmonary infiltrates or effusions. 30% have diffuse alveolar hemorrhage with hemoptysis. So they can present and be super sick. They can also have joint pain, GI tract involvement, fever. They can have palpable purpura. They can have ear, nose, throat involvement, neurologic involvement. And it tends to be a more dramatic presentation. Pauciimmune, the lung biopsy would show a pulmonary capillaritis with negative immunofluorescence. Skin biopsy, it's going to show leukocytoclastic vasculitis nonspecific. Their ANCA tends to be P-ANCA and MPO in about 60%. But remember, again, there's overlap. So, you kind of have to take the whole picture and figure out where things line up. But more commonly, MPA will have an MPO, P-ANCA. And then the next statement there, about 50 to 30% have C-ANCA. So your differential, again, same suspects, lupus, good pastures. Our treatment for MPA, pretty much like GPA. And a lot of times their course tends to be, whereas GPA, we see a lot of those patients go into remission and maintain remission. MPA can be a more aggressive disease, and at 20% of them will wind up on long-term dialysis. The pulmonary hemorrhage obviously can be life-threatening, and 5-year survival rate's about 70%. So not horrible, but it is a little bit more of an aggressive disease than GPA. And then Sjögren-Strauss, eosinophilic granulomatosis with polyangiitis, EGPA. Also a granulomatous vasculitis, small to medium vessels, can involve skin, peripheral nerves, lungs. It commonly involves peripheral nerves with a mononeuritis multiplex. Remember, GPA can too, MPA can too, but EGPA does more commonly. And a lot of times these patients have a history of allergies, asthma, nasal polyps, Adult onset asthma, about 95% or greater will have had that history. They have 3 phases. The prodromal phase, it lasts about 28 months and can last up to 7 years. They have the allergies, rhinitis, polyposis, asthma. They can have recurrent fevers. Then they move into the more chronic phase where myocarditis can develop, and that can remit and recur over years, and fever will be present in flares. And then finally, in the 3rd phase, they can develop the life-threatening vasculitis, and that on average occurs 3 years after they've started with the prodromal phase. Asthma can actually stop as they move into this phase, and they can develop the myocarditis, valvular insufficiency. They have the vasculitic peripheral neuropathies with the mononeuritis multiplex, foot drop, wrist drop, eosinophilic gastroenteritis, purpura, and testicular pain. The other clinical features, they can have the sinus tenderness. We've talked about kind of all the sinus involvement, asthma. They can have shifting pulmonary infiltrates that come and go. They can have nodular infiltrates without cavitation, pleural effusions, interstitial lung disease, pulmonary hemorrhage, the neurologic manifestations, rarely CNS or cranial, subcutaneous nodules, purpura, skin infarctions, the joint component, eosinophilic gastroenteritis with bloody diarrhea, abdominal masses, and even the eye involvement as well with corneal ulcerations and uveitis, prostatitis. So a lot of things that can be affected by EGPA, not as commonly as what you see with the lung, but can be. So the labs, typically you have the eosinophilia. Remember that eosinophils are very sensitive to prednisone, to corticosteroids. So if they've just come off a course of steroids, you're not going to see that. And that's confusing because we may not always get that history. They may have gone to the urgent care and been on steroids for 2 weeks and then come in and you get it and the eosinophils look fine. The eosinophils will melt away on the peripheral with steroids. Anemia, elevated markers of inflammation, IgE, if you check that, is often elevated. Rheumatoid factor. Their ANCA is also MPO, and that increases, if they're ANCA positive, it increases the likelihood of more severe disease, renal disease, alveolar hemorrhage, mononeuritis multiplex. So we think about EGPA when we can get that history, the allergy, asthma, if we can capture those elevated eosinophils, and we can confirm the diagnosis by biopsying an area where we can see necrotizing granulomas with the eosinophilic component. There should be eosinophilic infiltration in the biopsy to be consistent with EGPA. And then the granulomas are extravascular near small arteries and veins, and they will have a central eosinophilic core. I'm not going to go through 5-factor score, but it's there. EGPA, they are treated with cyclophosphamide and corticosteroid. Now there is mepolizumab, which targets the IL-5 monoclonal antibody. I have not personally used that, but Allergy Immunology is using that a lot. They're using it in their asthma patients. They probably are mitigating this disease in people and we don't even know it. But it can be used for full-blown EGPA as well. Okay. Is everybody still with me? A lot of ANCA all at once. So the questions here, we're just going to go through a few questions that touch back on the ANCA vasculitides. This patient's a 42-year-old man that was evaluated in the hospital for a 2-week history of progressive shortness of breath with hemoptysis developing in the past 48 hours. During the past week, he has also noted weakness of the left foot, numbness in the right hand, onset of rash. He has a 7-year history of asthma. His only medication is an as-needed albuterol meter-dose inhaler. On physical exam, temp is 100.4, blood pressure 142/87, pulse 72, respiration is 26. He has diffuse crackles in the lung fields, diminished sensation in the right hand, weakness on dorsiflexion in the left foot are noted, and he has palpable purpura. The remainder of the physical exam is normal. His SED rate is very elevated at 98. His white count 16,000, and eosinophils are 22%. Creatinine normal, IgE elevated, ANCA negative, MPO negative, PR3 negative, urinalysis normal. And his chest X-ray has diffuse pulmonary infiltrates. So they want to know which of the following is the most likely diagnosis. So we've got A, cryoglobulinemia, B, eosinophilic granulomatosis with polyangiitis, C, granulomatosis with polyangiitis, and D, microscopic polyangiitis. And so he's got pulmonary issues, neurologic issues with mononeuritis multiplex, history of asthma, labs, pretty classic with elevated sedimentation rate, eosinophils high, IgE elevated. So who votes for A, cryoglobulinemia, B, eosinophilic granulomatosis with polyangiitis, C, granulomatosis with polyangiitis, and D, microscopic polyangiitis? Okay, y'all got it. You're awake, you got the basic gist of that. So yeah, and I feel like a lot of times they are going to give you a typical case. It's an unusual disease and they just want you to recognize it. So I feel like they are going to give you the more typical case in your boards. So just to remember that EGPA. And now that they've renamed it, the name helps you to remember the manifestations. So question 2. Yes.
So how often are the ANCAs negative in these?
For G, all three. Okay, for GPA, if you're talking about limited GPA, which is just pulmonary basically, and a lot of times that's just sinus, 30% of the ANCA, 30% of the time the ANCA is negative.
Both ANCAs.
The whole panel, 30% of the time, which is frustrating because it makes it very challenging to nail down. But
also clinical diagnosis.
it is a clinical diagnosis, but you can kind of imagine that gets tricky when you're talking about a young female with maybe an early septal defect, nothing else going on, and you want to put them on prednisone and methotrexate, and biopsy doesn't help. ENT, and I should say on this that this isn't a one-man sport. This is a team sport. These diseases are. We are very dependent. I mean, basically, wherever the disease is manifested, if you're talking about eye, we are very dependent on ophthalmology. When you start talking about sinuses, we are very dependent on ENT, obviously with kidney, nephrology, and lung, pulmonary, but it's a team sport and we kind of have to work on it together. But for ENT, they're going to need, the scopes and looking at that, and they probably will get a biopsy, but the problem is it's not particularly helpful. It helps, ENT helps us rule out a chronic infection, and that is very helpful because we're talking about immunosuppressing them. But fortunately, it's a rare disease presentation, but it's hard to nail down. So for systemic GPA, you're like at 95% ANCA positivity. So that's very helpful. When you're talking about MPA and EGPA, MPA is like at 60% and EGPA is about that as well. So pretty helpful, but EGPA gives you a lot of other clues that can help you zero in on that. Microscopic polyangiitis, honestly, rheumatology doesn't usually get involved in that. It is an ANCA vasculitis, but they come in really sick, and that's usually pulmonary and renal working through that. So, yeah. Okay. 52-year-old man is evaluated in the hospital for several episodes of hemoptysis that developed over the past day. He reports reports feeling well until about 3 weeks ago when he developed myalgia, arthralgia, occasional nosebleeds, and diminished hearing. 1 week ago, he developed a rash and weakness in the right hand. History is otherwise unremarkable, and he takes no medications. On physical exam, temp 100.4, blood pressure elevated at 152/100, pulse rate 72, respirations 24. He has conjunctivitis in both eyes. He has decreased hearing in both ears. He has maxillary tenderness, chest exam. He has rhonchi, right hand, decreased grip strength. He has palpable purpura and bilateral lower extremity and of the bilateral lower extremities. So if you think back to that original slide I showed you, a lot of stuff going on here is would make you think about a vasculitis. Of course, the palpable purpura and then the motoritis multiplex, where he's got weakness in that arm. And then the hemoptysis for the pulmonary manifestation. Your SED rate is 84 on him. His white count, 12.3, eosinophils less than 2, complements normal. Creatinine is elevated at 2.1. Urine, he has 3+ protein, 50 red blood cells, 20 white, and mixed cellular cast. The sinus x-rays show bony erosion of the septum and turbinates, and the chest x-ray shows diffuse infiltrates. So which of the following is most likely to establish the diagnosis? A, anti-double-stranded DNA antibody level. B, anti-MPO antibody level. C, anti-PR3 antibody level. And D, serum cryoglobulins. So just to recap, labs, looks inflamed and active urinary sediment, and he already has renal compromise. No eosinophils and complements are normal. So, and then the sinus radiograph with erosion. So who would vote most likely to establish diagnosis? A, any double-stranded DNA. Because what are we thinking about there? Thinking about lupus, and one of the clues there, although not absolute, is that the complement was normal. So they're trying to let you know we don't think lupus or active lupus. B, any MPO antibody? Anybody? Maybe, maybe not. Yeah. C, anti-PR3 antibody. And then D, cryoglobulins. Now, nobody is going to fault you for ordering all of those tests. And in the real world, you would order all those tests, right? But he has the clue here, because when you're thinking about MPO, PR3, when you're differentiating between those two, like we talked about, there is overlap, but the boards on these kind of diseases that are so rare are going to give you the typical pattern. So when you're thinking GPA, you're going to think PR3. When you're thinking MPA and eosinophilic granulomatosis, polyangiitis, you're going to think MPO. So the question here is, are we dealing with a GPA? Or are we dealing with an MPA or eGPA? And what differentiates this, there are two clues here, because there's overlap in all this stuff. Most of them can have any of this, some more commonly than the others, but you want to look at the typical pattern. But what differentiates here is no eosinophils. So if they wanted you to think about eGPA, they're going to have eosinophils there. That's not there. And you've got they did give you the sinus radiograph, which, to be honest, we don't get a lot, but they're showing a bony erosion. And so then you're thinking, well, what affects the sinuses? Well, MPA doesn't affect the sinuses. GPA does. eGPA does, but we don't have any eosinophils. So that's going to push us back to GPA. We're going to be thinking PR3. So the answer they want there is the PR3. Does that make sense? So when you're studying these diseases, think typical. What is a typical pattern? When you're in real life, no, it's not typical. That's why we go over there. Y'all call us and we're struggling to figure out what's going on, because it's not typical. But when you're taking these boards, think typical, always get a biopsy, you know, and you should do well on those questions. Okay, number 3, a 65-year-old man is seen at the request of her ophthalmologist, or excuse me, a woman. 2 days ago, she was diagnosed with scleritis and began using ophthalmic prednisone solution. She notes progressive fatigue, intermittent episodes of sinus congestion during the past 5 weeks. 10-year history of joint pain in her hands and low back pain that has not changed recently. History is also significant for high blood pressure, diagnosed 3 months ago. She takes hydrochlorothiazide. She has no shortness of breath, cough, rash, diarrhea, or abdominal pain. Her vital signs are normal, ears normal, right eye is injected, mild redness and crusting in the sinuses, no oral ulcerations, bony enlargement with tenderness over the DIP joints and squaring of the first CMC joints bilaterally, which what is that? Almost always. That's osteoarthritis. And if they've got it on your test, that's just run-of-the-mill osteoarthritis. So there's nothing there that should get your attention. She's just got OA there. Mild lumbar and paraspinal muscle tenderness is present. Full range of motion of the lumbar spine is noted. There's no SI joint tenderness. The remainder of the exam is normal. CMP normal, sed rate 55, hemoglobin 11, white count 5, platelets slightly up at 550. UA protein, 2+ protein, trace blood, no leukocytes, 1 red cell cast, chest x-ray normal. What is the most likely diagnosis? So scleritis, which is a worrisome eye finding. When you hear scleritis, they need to get treatment. That you lose vision over. Fatigue, sinus congestion. So pretty much all up here. Labs look a little inflammatory, platelets up a little, sed rate up a little, urine a little abnormal. So they talked about her back, but she's had 10 years and no change and just a little tender. So we've got ankylosing spondylitis, Behçet's, granulomatosis with polyangiitis, and sarcoid. Anybody in favor of ankylosing spondylitis, chronic inflammatory spine? Not sounding like that. Behçet's, you remember mucosal ulceration, vaginal ulceration, didn't say anything about that. Granulomatosis with polyangiitis. Yeah, thinking maybe that. And then sarcoid. Chest x-ray normal, sarcoid's more typically uveitis. So probably not that either. So I know we're talking about ANCA and I'm giving you all these ANCA ones, but that one's going to be GPA as well. So
this is a limited.
probably, but there's a little bit of protein. So you'd want to keep an eye on it. But we talked about that too, because about 10% can generalize. Okay, last one. I'll go real quick. 32-year-old woman, 3-month history, dyspnea on exertion, dry cough. She continues to jog 3 miles, but notes that it takes her longer because she's getting short of breath. No other symptoms, no meds. Physical exam normal, lungs clear. She has skin thickening on the back of her hands, forearms, face, and thigh. Chest x-ray normal. In addition to getting pulmonary function tests on her, what is going to be the most helpful in establishing a diagnosis? You're probably going to order all the blood tests, but there's one that you would want to get. So A, anti-PM-SL70, or excuse me, anti-PM-SL antibody testing and bronchoalveolar lavage. B, anti-SL70 antibody testing and high resolution CT. C, anti-centromere antibody testing and lung biopsy. D, ANCA and gallium. Who votes for A? Who votes for B, anti-SL70 antibody testing, high resolution CT? C, anti-centromere antibody testing and lung biopsy. D, ANCA antibodies. I threw y'all off. This isn't an ANCA answer, but y'all knew it. Nobody voted for ANCA. Okay, so she is sounding like she's turning into generalized scleroderma, a systemic scleroderma, and the testing for that would be B, SL70 and a high resolution CT. So the anti-centromere antibody and lung biopsy, probably most of y'all wouldn't jump from a chest x-ray to a lung biopsy anyway, but the centromere goes with a limited disease, and she's presenting with a more diffuse pattern, multiple areas involvement, and already is indicating lung involvement. So that would push you back to be the systemic sclerosis. All right. Sure. Yeah, there's probably a lot of stuff you'd be doing, but they just want to know 2 things. Yeah.
You mentioned that the underages, when they're positive for EGPA, that's like the worst prognosis. Is that great?
Yeah, that tends to be the case.
Is
Yeah.
that the case for the other, ANCA vasculitis?
Not for GPA, because remember, most of GPA does have an ANCA vasculitis. And so probably for MPA, I can't answer that on MPA, to be honest, because MPA is just a more worrisome disease. But GPA, because of rituximab, these patients can really do well. So I don't think we could have said that 20 years ago, but that's just been a real blessing.
There's a fairly high rate of false positive PR3s, MPOs, all that, right?
Yeah. Yeah.
So don't indiscriminately order with someone who has systemic, like, inflammatory symptoms. You want to really something that's
Yeah,
like kind of high pretest possible.
right. Yeah,
We order those. Sometimes it seems like it's just kind of like you're describing, like a rheumatologic order set, but then
Right.
you don't know what to do with a PR3.
I know. That gets hard for everybody. But especially on the inside and inpatient side, I'm not going to tell you not to do it because I would defer to your attending. There are times, I mean, we've all seen it. If you talk to nephrology and pulmonary, we've all seen it, that you order those early on and you're thinking you're treating community acquired pneumonia or whatever. They don't get better. These come back positive, and they take so long to result out. So we've all had that experience. So I don't want to discourage it, but I wouldn't just indiscriminately order them. Yeah. So. All right. Learn something. I don't know how to get out of here.
Thank you so much.
You're welcome.
Oh.
You doing good?
you're- so-
Yeah. The